Respected all, I am going to present on topic clinical and radiological outcome of anterior stabilization of aortic B and C cervical spine injury. Coming to introduction, the cervical spine injury occurs in 2.4% of the blunt trauma victims. Type A injury are 14.7%, which are compressive only lesion. Type B are 43.9%, which are flexion, extension and distraction injury, and type C 41.2%, which are rotational and translation injury. AO type B and C injuries. B injuries are tension band injuries. B1 is posterior tension band injury where fracture line passes through the bony structure. Type B2 is posterior tension band injury. B3 is anterior tension band injury. Type C are the translation injuries. The advantage of the anterior approach often includes supine positioning of the potentially neurologically compromised patient, familiarity, minimal surgical trauma, and direct anterior decompression of ventrally compressive structures such as disc and bony fragments. The patient with cervical fracture dislocation, which are combined with in-spine cord injury, often requires an anterior approach as this is the most direct way of the surgical decompression. Also, there is less muscle splitting and an easier dissection, and so it is better tolerated, and the anterior column can also be constructed directly. The general objectives is to evaluate clinical and radiological outcome of anterior stabilization of AO type B and C subaxial cervical spine injury. Specific objectives are to assess radiological outcome with C spine lateral X-ray, to assess the clinical outcome by pain, by bias in NDI, and neurology evaluation by ACI grading. The study design of my study is hospital-based prospective observational study. It is done in National Trauma Center with sample size 21. The radiological outcome was assessed gathering all preoperative and post-operative radiological data with C spine lateral X-ray in flexion, extension, and neutral position at 6-month follow-up to see fusion and instability, and clinical outcome was assessed by using the score, PAS, NDI, and ACI neurology. The post-operative radiograph was taken on the first post-operative day, and follow-up radiographs was taken at 6 weeks, 3 months, and 9 months follow-up. The latest follow-up radiograph at 6 months it used for the analysis. Inclusion criteria: all patients having undergone anterior only cervical fixation procedure for subaxial AO type B and C subaxial injuries, and patient who give consent for study and age more than 17 years. The exclusion criteria: patient undergoing initial posterior fixation or planned circumferential fixation, patient with compressive or burst fractures, and patient with a fracture found to be related to neoplastic or infectious etiology. The bias or visual analog scale is used in one of the tool for my study for clinical assessment, and neck disability index is also a tool for clinical assessment where the different 10 parameters are there with total score of 50. Coming to results, out of 21 patients operated, 14 or 66% were male and 33% were female with the mean age of 39.9 years ranging from 17 to 70 years. 12 or 57% patient were AO type B injury, and 9 or 43% sustained AO type C injury. The mode of trauma: the most common mode of injury was fall from height that occurred in 14 or 67% of the patient. That was followed by RTA and 6 out of 21 or 29% of the patient, and physical assault in 1 patient. Coming to neurology, preoperatively 1 patient had ACI-A neurology, 2 had ACI-B neurology, 4 had ACI-C, and 4 had ACI-D, and 10 had ACI-E neurology. And post-operatively 1 patient had ACI-A neurology. There is no improvement in ACI-A neurology, and 1 had ACI-B, 2 had ACI-C, 4 had ACI-D, and 13 had ACI-E neurology. No new neurological deterioration was observed. So this diagram shows the significant improvement of the ACI neurology in one level by one level in ACI B, C, and D. Coming to other is bias score. The bias score 6 or 29% of the 21 patients had no pain, 12 or 57% had mild pain, 9.5% had more moderate pain, and 1 had severe pain with a mean value of 2.7 plus minus 3. Neck disability index 9 patient had mild disability, and 8 or 38% had no disability, 2 had moderate disability, and 2 had severe disability according to NDI, and with the mean value of 7.57 plus minus 7. And instability was defined as radiographic failure. Where the radiographic failure, it was defined as a uh, change in translation of greater than 3.5 mm or change in angulation greater than 11 degree. It was present in 2 patients, and in 1 patient both were present. Fusion was assessed using the Brightwell criteria. Of the 21 patients, 14 or 66% patient showed grade 1 fusion, 6 or 31% patient showed grade 2 fusion, and 1 patient showed grade 3 fusion. In a similar study done by Mitchell J. Johnson et al., uh, the radiographic failure was 13%. In my study, it was 9.5%, which was comparable. The fusion grade 1, 2, and 3 were also comparable with no gross fusion failure in my study. The neck disability index was compared with the similar study done by Ankit Sasan et al., where no disability, mild disability, moderate, and severe disability were also comparable. In neurology, was also compared with the similar study done by Ankit and Sasan et al., where the improvement of the neurology level by 1 level was found which was also comparable with this study. BAS score in my study was 2.7 plus minus 3. In a similar study done by Richard yes Woodworth et al., it was 1.47 plus minus 1. So conclusion: anterior cervical stabilization is good and safe method and has benefits of high primary stability, anatomical reduction, direct decompression of spinal cord with minimal complication, good fusion rate and neurological recovery, and when a short operative time is preferred. Thank you.